Hola a todos, bienvenidos. Ya está Raymond Douglas en el público y faltan un par de minutos, pero les quería contar que tenemos... Oh, oh. Ahora sí, eso era porque YouTube quedó prendido. Entonces, hola, 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 hola. Les quería contar que tenemos ya 502 aprobados con su registro y ya hay 117 participantes en la reunión. Así que vamos a seguir dándole unos minutos más a todo el resto para que suba. Queremos hacer una previa. Están todos diciendo buenas noches. Está Mirta desde Paraguay, Ángela de Bogotá, Jaime, hola, de Colombia. So Raymond, we're just waiting for the rest of the people to join. There's 120 that already did join, but we have 502 that registered. So I think we should wait a little bit more. It's still not 8 o'clock, so we can still be waiting a little bit. Maybe you can tell us a little bit of how confinement, what are you doing? Hi. No, you should be able to talk now. Yes.
It should be okay now. Yes, we're both trying to unmute me at the same time. But confinement has been going okay. I guess we've been getting some of those things done that we've been putting off for so long, whether they be papers or cleaning out the closets. So that's kind of what I've been doing, and at least getting on a few bike rides, which has been at least a little fortunate to escape every once in a while on a ride. And certainly doing a little Peloton just to try to keep in shape. How about you? You must be feeling the pressures by now, like everyone else.
Yes, so now that we are going back to work, we've been all talking a lot more because, taking measures and protocols, and a lot of our colleagues have seen very, severe cases that have been waiting for the last couple of weeks. So we're gonna, I think we're all gonna jump into work pretty hard. Yeah.
That is the goal. I think our institution is going to kind of have a soft reopen, meaning that they're going to have priority cases. And I think they do a lot of transplants and such. I think that the transplant surgery will come on, and then eventually I think that we're kind of coming up to speed also. So I think it'll be a little bit of a transition zone for us.
Okay, so you're going to go little by little. Cristina Hidalgo is the president of SOPANOP, and she joined, and she's there. She has her mic up. So, hola, Cristi.
Hola, hola. Thank you, Dr. Douglas, for accepting our invitation. Thank you very much. And a really pleasure for all of us stay with us in this meeting. Yo creo que vamos a esperar un poco, ¿cierto? Que se conecten todos.
Sí, definitivamente. De repente le queremos preguntar algo más sobre lo que está pasando en California. So why don't you tell us a little bit more of how's your practice in California? Because you used to be in a university hospital, and now you're also you're in Beverly Hills, and I see that you're traveling a lot to China.
Yeah. So we've I have a practice that's kind of split between academic medicine and private practice in Beverly Hills. So I operate and have the academic component at a Cedars-Sinai hospital, which is a private hospital, but it's about the size of a decent academic center. In fact, we're about 40th on the NIH research funding list. And so we collaborate a lot, but I also have a laboratory in the Stem Cell and Regenerative Institute. So that keeps our research going, I think, quite well, especially in the basic sciences. And then they also are very supportive of the clinical trials that we've been working on. And so it's been a nice mix where I can kind of have the academic university environment, but then also, kind of shuffle off to the private practice. And when I get bored of that, I can go back and hide in the other place. So that's usually how it works for me.
Yeah, I know you, so I'm sure you have plenty of works. And do you have fellows in Cedars?
Yeah, so I have my own fellowship through ASOPers, and then we also have residents. They're mostly joint residents with UCLA and USC. So they also have their own residents in ENT who join us quite a lot. But our own fellow is Yao Wang, who's has another year left with us. And actually on our papers, one of the primary authors was my last fellow, Amy Patel. So they get very, very involved in research and also surgery. So hopefully we give them a little bit of a mix. We're probably in the time when we can hopefully do international fellows soon. So we're getting to that point. So hopefully it'll be, fun, but we enjoy teaching. That's the fun part of it all.
I know you do. So should we start?
And it's been a little over a year since I was in Colombia. Jorge Corona just sent me a photo that was awesome of just our time there, just about a little over a year ago. So it was such a memorable, wonderful trip, and really enjoyed it.
So Jorge Corona is here, and actually what I'm gonna do is Hola, Jorge.
Hola, Chris, ¿cómo están? ¿Cómo estás? Raymond, how are you?
Doing well. How are you doing?
Doing very, very well, thank you. Well, what I want to start first is to thank you for taking your time to present what you have accomplished in a way that now I think it's going to be worth of a Nobel Prize someday.
You're too kind.
my opinion, but I first want to say, want to thank Juan Andres. Juan Andres was instrumental in bringing Raymond on today's conversation. So I want to thank Juan Andres for doing that. And Raymond, really, we cannot thank you enough for showing us what you're gonna show us tonight. When we were in Barranquilla in Colombia last year, a lot of the things that was not yet FDA approved, so it was very close. So you could share as much as you can without sharing everything. So we're so excited about listening to your lecture today. I heard your lecture a few weeks ago. Once it has been approved, it's fantastic. So everybody is looking forward to hearing tonight. Raymond is so accomplished. He got his medical degree and PhD from University of Pennsylvania. So he has a very strong background in immunology. And as we know, thyroid eye disease is almost like an immunological disorder. He then went on and did his facial and reconstructive plastic surgery at UCLA, Jules Stein. And he's had many appointments. He's been working at the Los Angeles VA, at UCLA. He was at some point at the University of Michigan. And right now he shares his practices between Beverly Hills and Shanghai. We talked a lot about Shanghai last year. And right now, of course, with all these lockdowns, it's difficult, but, extremely impressive positions in both countries. And what we're excited, or at least I am excited about hearing tonight, is that he already, before all these TPISA we're going to hear about tonight, he was already an incredibly accomplished surgeon, and he has done a lot of the aesthetic orbital decompressions. So he already, from the surgical and technical aspect, he was already doing a lot of that. So his combination between being an aesthetic orbital surgeon and an immunologist and a PhD, I think is going to be a great combination for all of us. He is just a scientist, a surgeon, a world leader, and a great teacher and a friend. So we are so excited he's here with us tonight. And we thank every one of you guys for listening to Raymond tonight. So Raymond, thank you so much and welcome.
Well, thank you. I'm not sure that I can give a talk that's as good as that introduction. So I'm quite humbled by that. That's quite nice, and I hope that everyone enjoys a little bit of the discussion. Anyone can always reach out via my email, or it's often easier in the day of social media, just on my Instagram, Dr. Raymond Douglas, and just ask me a question or something if there's, and then we can always connect via email or whatever you need. So I hope that you'll find the data interesting. I will talk a little bit about surgery also, and we can, if you'd like, talk about how that is, may fit together even in the future.
So Raymond, Cristina is going to give us the formal welcome, because now it's almost 250 of us, and I think we could start. And then I'll introduce the discussion panel so that everybody can do their questions, and then at the end of the lecture. So Cristina, please.
Bueno, vamos a hablar un poco en español también, en English. Bienvenidos todos en nuestra quinta reunión SOPANOP. Estamos realmente muy contentos porque hemos crecido y hemos ido creciendo en número, en presencia en Zoom, en YouTube, y porque todos ustedes que están aquí son parte tremendamente importante de que todos somos SOPANOP. Así que muchas gracias por estar acá. Ya Jorge hizo la presentación de nuestro invitado, y I want to welcome Dr. Douglas to our SOPANOP meeting today. It's a great pleasure for us to have you in this meeting and share with all of us your experiences and work in trepotumumab. SOPANOP, la Sociedad Panamericana de Oculoplástica, want to expand bonds with all Oculoplastic Society and become a worldwide platform for discussion and communication in oculoplastic. Thank you very much. And Josie nos va a explicar ahora cómo seguimos. No se escucha. Josie, no se escucha.
Ahora sí. Gracias, Cristi, y gracias, Jorge, por introducirnos a Raymond. La verdad es que estamos todos súper contentos, pero además tenemos un panel especialmente diseñado para canalizar todas nuestras preguntas y poder generar así una discusión entretenida. Así que te saludo, Dani, que tienes el micrófono abierto para que saludes a todos.
Aquí estamos, un placer enorme placer de tenerlo a Douglas acá en una cosa completamente nueva y que quizá innove el Graves. Muchas gracias. Thank you very much.
So Danny Weil is from Argentina, and he's very, very excited of listening to what you have to say. So there's also Rosa Balcells from Chile, who's going to be part of the panel. Rosita, ¿quieres saludar? Te tenía abierta. Yo abro y cierro y ahí. Ahora sí.
So,
Rosa.
well, it's a pleasure. You already heard it, but it's a pleasure and it's an honor for us in SOPANOP to have you, Dr. Douglas, here. So we're looking forward for your experience. We all know, all the oculoplastics know how hard the thyroid eye disease is sometimes for us to treat it and to see our patients not having great results. So we're looking forward to all the new, developments and treatments, and we know you are, leading lots of studies and stuff that we're looking forward to hear you tonight. So thank you very much for being here. And we are really like waiting to hear you. So go on.
I'm taking a little bit of time just because I know there's so many people that registered and so I think we can start right now because it's already 280 people. So we should start. So please, Dr. Douglas, share your pantalla. And please remember that most of our audience knows English, but you can go slowly. So that would help everyone.
I will definitely. I'll share my screen to start. And again, it's, one second. It really is my pleasure to be here. I really enjoy the Zoom platforms now that, you know, really allowed us to connect in so many ways that we haven't been able to do in the past. And it really is quite my pleasure to talk about this particular subject. And I would really appreciate questions and anyone who has interest to share them, because I think that's how we will learn and expand the knowledge of what to do next. And I think that's the major question, is what we will do next. So this is the new advances in the management of thyroid eye disease. And again, if anyone, you know, they can email me, but also my Instagram or direct message, WhatsApp, you know, whatever needed to just connect and ask any question that you may want. I do have financial disclosure, the consultant for Horizon, also for Immunovant Corporation on just my Instagram. So I think that this audience is very familiar with thyroid eye disease. And so I'm not going to spend a long time, but I do want you to think of it and sit back and think of it in different terms, maybe. And instead of just classifying the disease, the first steps I want to go over and think about is how you would draw the correlation to the basic science. So let's think. We know that most commonly associated with hyperthyroidism, and this is from the autoantibodies that are generated to the TSH receptor. We know that most of the time, the thyroid eye disease develops with Graves' disease. So likely there's some link to the immune system attack upon that receptor, or a receptor that's quite related, which is going to actually be the IGF-1 receptor that sit right next to each other. So the immune system, you can imagine already that it fulfills these clinical criteria. We don't know why more women than men are affected, but we are looking into that. And then clinically, this all manifests as eye bulging, proptosis, the retraction, strabismus, eyelid edema, chemosis, and even compressive optic neuropathy. And we're going to talk about this, but you can already see that there's inflammation and new tissue deposition. New things are being added that's causing the eyes to bulge, in addition to inflammation. And we know that this is a progressive and debilitating disease. And I think this slide really wants just to stress that our patients really do suffer with this disease. Even when I can do surgery, I often can't do surgery for many, for years, or their whole process can take many years. So we would love a better option, and we know how these patients do suffer. We also, again, thinking about this disease, we've always categorized this into an active and an inactive phase. We think of the active phase as the immune inflammation, the immune activation. And that's probably correct. It's probably that there is a heightened immune reaction during this active phase. But part of what this doesn't explain is, well, why doesn't this just heal like every other autoimmune disease? Is there a continued activation to prevent the new tissue that's been accumulated from just going away? We know that scars soften over time and our body heals, so there may be something different here, but at least it's very evident that there is an inactive phase that primarily is devoid of new immune cells, these two stages. So we have these two things, inflammation and tissue expansion. And with tissue expansion, I really mean that everything that we see, the extraocular muscles get big and they get scarred. Remember, there's new fibroblasts that are placed in between the muscle cells, almost like encasing a muscle in concrete. It just can't move as well and causing that scarring. That's not necessarily due to inflammation. That is due to scarring and the response to inflammation that often occurs. So we can begin to maybe think about these as two separate but very much overlapping molecular processes. So we can think of—
I found this on the web.
Sure. We can think of the clinical manifestations of thyroid eye disease as being variable. So we know that there's short-term things that we can deal with in this active phase. And that's kind of the many of the redness, many of the things that we've associated with the active phase, the redness, chemosis, swelling. And then there are the long-term consequences that really bother our patients the most. The double vision, lid retraction, even losing vision. And these are the things that are hardest to deal with because we try to do surgery for them. And we've come up with some good tricks during surgery. I've learned, many things from many people to try to, camouflage this disease, but it doesn't reverse these long-term consequences. So the consequences, as I think this group already knows, it really can be quite devastating. And dry eye, double vision, blurred vision really just leads to an incredible reduction in the quality of life for these patients when they have the permanent disfigurement, which cannot be underestimated. These patients have very high suicide rates, and this really affects them about the same as the rates that we would see for breast cancer and for other things like that. So we've come up with a grading and, in thinking about how we're going to approach this disease many years ago. And I think that one of the things that we've done in these trials is kind of focused on the disease that everyone would consider thyroid eye disease worth treating. Now, that doesn't mean that that's the only thing that we should treat. In fact, I would argue not. I think that there's many things, other things we could treat. But in terms of a clinical trial, which I'm going to begin to shift towards, you really have to define what our endocrinologists in England or Europe would find as an appropriate disease, and what everyone in all of our sites would define as an appropriate disease. And I think that moderate to severe disease is pretty reasonable for a trial. And we began, to think about what treatments already exist. Well, and I think to think about what treatments exist, you have to think about what you're treating. We know that for inactive thyroid eye disease, we've had many trials and many things that have failed, and there's no real reduction in proptosis or double vision or any of these except by surgery. So for inactive TED, and we as surgeons treat with surgery. And I think in many patients, they do very well. But for the active disease, we've often argued, well, is there steroids, biologics, radiation? But I think one thing that's very, very important to remember is that none of these treatments during the active phase make any difference on how much surgery you're going to do, or make any difference in the strabismus or bulging of the eyes that are the long-term consequences of this disease. And I think that's really where the FDA, and one of the reasons why the FDA has never felt compelled to approve any of these treatments for thyroid eye disease. Those often do require multiple clinical trials to show efficacy. And I think efficacy has to go beyond just treating the swelling and the redness. It has to reverse the disease. And that's really what we want to see is reversal of this disease. So we know that systemic corticosteroids are used very often, and I've used them very often too. You know, when you don't have a lot, you know, that can alter the disease, you try what you can. But we know that they don't alter the course of the disease. They can make the symptoms better. They can often, you know, improve some of the symptoms, and we try to, you know, make it to the inactive phase so that we can do surgery by using steroids. But we don't, you know, we also know that they have lots of side effects. And we know that they have, you know, problems up to 50% of the patients having significant side effects, you know. And so I think that it always tempers our enthusiasm of who to use it for and then following these side effects. We know that there's even been deaths associated with what was considered hepatic failure associated deaths in many of the trials that, you know, were done out of Europe. And there's been various dosing schedules described, and, you know, and I think you can look at, you know, these. And I think Bartolina's paper in 2012 was one of the better ones in comparing all the dosing regimens. But what was most evident is that this really didn't reverse any of the proptosis or strabismus of these patients. It did get rid of the swelling, you know, in quite a few with a very high rebound, but it didn't change the disease. And so we've always been searching. This just defines the need for a new approach. And this just shows, you know, whether you use, you know, IV prednisone or rituximab, you just don't see much change in proptosis, whether it's low dose, high dose, whatever that may be. Though you do see a little bit of a reduction in the clinical activity score. And I'll show, you know, a note here, you know, a minus 1.8 and a minus 2.7. So I think we'll want to remember those as far as how, you know, rapidly that, you know, takes place when we look at something like teprotumumab in the later data. And I used rituximab and used these a lot. So what's the bottom line of where we go? We know that steroids don't reverse the underlying disease and the alterations of the tissue. Remember, that's what we started off talking about, is that alteration of the tissue, the fibroblasts, those cells coming in and altering what appears in the muscle size, the muscle volumes, the muscle stretching that is causing so much problems for double vision or proptosis. But they do have side effects, you know, steroids. And tocilizumab, steroids, radiation, you know, none of them have shown to really reverse proptosis or strabismus certainly in any long-term way. I do think that they impair the immune system, you know, in very interesting ways, and, you know, could be useful in some settings, but they really just haven't shown reversal of those long-term findings. So really in thinking about a cure, I had to really think, you know, take a step back and think, what's the biology of this disease? We already talked about the immune system attacking and, you know, some potential receptors and causing hyperthyroidism and these muscles to swell, or the fibroblasts. And really it is coming back and thinking about the molecular targeting of what's going on in the immune system. And that is the antigen. That's what the immune system targets. And to think in those terms, we have to really delineate what's the common molecular mechanism. The patients are very, very different. Some have fat expansion, some have muscle expansion, some have inflammation, some don't. But what's the common molecular mechanism that could interrupt this process? What would be the highest chance? And I always refer to this as a tree. We have many branches on the tree, many types and forms of disease. And many of us have spent a long time characterizing each branch of the tree and saying how one branch is very different from the other branch. And it may be molecularly, but at the root of it, or at the trunk, there likely is a common molecular mechanism that sparks all these branches. And that is, I think, the real target. Rather than each branch, we want to target the trunk of the tree to really interrupt this process long term. And this developed from work looking at the IGF-1 receptor, the insulin-like growth factor 1 receptor. It's no doubt that the TSH receptor is important in this disease, in the manifestations of the thyroid. But unfortunately, we just couldn't really link anything in the laboratory to the TSH and the eye disease, and that's been a struggle. But it turns out that there's a very interesting story with the IGF-1 receptor and in its linkage even with the TSH receptor, which I'll explain. So what is the insulin-like growth factor 1 receptor? Well, it's an auxiliary receptor for the insulin-like growth factor 1. It's not the primary receptor for insulin, so it doesn't primarily control blood sugar, but it is expressed on a variety of cells in a very low amount. Now, what's interesting is that most times it's expressed in a very minimal way, but it's very much overexpressed on Graves' disease fibroblasts when we started to look at them. And not only is it overexpressed on the fibroblasts of these patients, from the orbit specifically, not from other locations nearly as much, but primarily in Graves' patients and in other cells from these patients. So the overexpression of this receptor really, I'm jumping ahead, but it really is part of that trunk of the tree. This is a finding that's been very consistent and I think helps to explain these findings. What we also know is that if you signal through this receptor that's overexpressed, you begin to mimic the pathologic findings of the disease. You get fibroblasts to proliferate, you make cytokines, you activate T and B cells, do a whole bunch of things that make you think that this is very important specifically in this disease. And it turns out there are antibodies to these receptors that may also help to stimulate these in Graves' patients. So what's the data here? Well, the data is that this is an overexpression in one cell type and showing the hallmark, and this is in T cells. We did this now, it's hard to believe we did this now in 2007 when I first, almost came into the lab. But it's been replicated in B cells, in monocytes, even in NK cells and other, fibroblasts, of course, but that IGF-1 overexpression is the hallmark of Graves' disease. In fact, we looked at all the twins in Denmark and found that the overexpression of the IGF-1R is not related to being a twin. It's related to having the disease. So it really seems to be a hallmark of Graves' disease. And it is different and not a hallmark of other autoimmune diseases such as rheumatoid arthritis and ulcerative colitis, or much less so, especially on T cells. So there is a specificity to this process.
I didn't get that.
I'm not sure why that keeps popping up. Well, that explains part of the story. Now, how do we fit in the TSH receptor to this? Because otherwise, that's two very different stories and two very, very different processes that might be going on here. And it turns out that despite being very different receptors, these two receptors interact and actually form a bond between them. And so much so that when you activate one, you actually activate many mechanisms of the other. And this was very surprising because these are very, very different receptors, but they coalesce. And this is kind of a pictorial representation of immunofluorescence and immunofluorescence, showing that these two receptors are actually linked. Then we also have functional data shown by us and other groups showing that the function of these receptors is actually linked. So no longer do we have two separate stories. We have one very overlapping story. And so we kind of call this the Graves IgG, activating the central receptor process, leading to all this inflammation and monocyte and all the downstream reactions. And I'm going into so much of this detail because I really want you to understand that IGF-1R and teprotumumab was not just picked off a shelf. It was actually very carefully chosen to treat specifically this disease. So here's a cartoon characterization of what I'm thinking, of what I'm showing. You have the TSIs, or these, something that's activating the IGF-1R TSHR complex. And what happens is this complex gets activated, and then there's an influx of immune cells. And just as we were talking about from the very first slide, the fibroblasts proliferate, and then there's hyaline and scar tissue that's placed in between the muscle cells, almost forming a concrete between these muscle cells, preventing them really from adequately functioning. And you get proptosis and double vision. That would be the idea. Well, the idea of a medicine to actually block this interaction is something that we thought of very early on, that you could block this receptor. So instead of activating it, an antibody in this case would bind to the receptor, block the signaling of this receptor complex, and likely cause internalization and kind of take it off the radar for the immune system to attack. And that's a very basic thought process or hypothesis of what could happen. And again, just as the last science slide, but just to remember the major points, that the IGF-1R overexpression is a hallmark of this disease, and it's site-specific. It's in the orbits of these patients. And the activation of this molecule with the TSHR seems to replicate all the findings that we would expect based in a laboratory dish. Now, rarely does anything that you make in a lab translate immediately into the clinic. There's more than 1,000 reasons why that theory could be wrong and would never work. Well, in theory, we want to try at least a medication that is going to form an ideal treatment. And that would be going after the trunk of the tree. But not only does it have to work on a molecular level, it also has to then translate that molecular function to what would be considered an ideal treatment that people are going to use. And here that's characterized, and I've made a few check boxes to see if we fulfill those, as something that will decrease inflammatory signs, something that will reduce proptosis and that underlying pathology and those changes that we've seen, something that will reduce double vision. It's a very big concern of patients. We can reduce proptosis with decompression, but double vision goes up. We want it to improve quality of life, and it has to have minimal side effects. We can't kill the patient, and eliminate or minimize or transform, I always say, the type of surgical treatment that we'll be doing in the future. So what clinical manifestations should we be looking at in a trial? Well, there's short-term things like swelling, redness, CAS score, but really it's the long-term manifestations, the eye bulging, disfigurement, double vision, quality of life, and facial changes that really make the long-term process require surgery. And so that's where we want to focus, and to see how a potential therapy would be better than steroids or the things that we have. So along came teprotumumab, and the idea for teprotumumab was formed long before. But teprotumumab is a fully human monoclonal antibody to the IGF-1 receptor. We didn't make teprotumumab. Teprotumumab was available. It was actually used in sarcoma trials, and it failed in those trials. It didn't seem to make a difference. But it was a very nice molecule because it was a human monoclonal antibody, and it inhibited the IGF-1 receptor. So it was a perfect molecule to potentially test some of these theories of targeted binding to the IGF-1 receptor and the TSH receptor signaling complex. And then we could, by turning this off, we could see whether there's blocking of inflammation and proptosis and everything else behind the eye. So this is the idea behind the clinical trials, that in this active phase, or what we think is probably the most vulnerable phase, we could give a drug here, teprotumumab, and during this phase to see if there's a reduction in the disease severity at the end of this process. Is there really a reduction or not? And that's what we wanted to know. The phase 2 and now the phase 3 results have both been published in the New England Journal of Medicine. And I'm going to go through a bit of what this trial looked like, and then much more specifically with the results. So the phase 3 and phase 2 were very similar. This was a 24-week randomized, double-masked, placebo-controlled treatment of teprotumumab. I didn't know what they were getting. No one else did. They're given these infusions every 3 weeks for 8 infusions. And the choice of patients had to be patients that satisfied criteria in Europe. In the US, they were had a clinical activity score of greater than or equal to 4, and they were euthyroid. And they had to have disease onset less than 9 months. And so we felt that that would be a group of patients for the clinical trial that everyone could agree upon. And the primary endpoint is probably the most important aspect here. Instead of just a reduction in the clinical activity score, which you can achieve with steroids, we really wanted a reversal of the disease, something that we could say was disease modifying. And we felt that a primary endpoint that included proptosis would be both accepted by the FDA and also by our peers as something that truly can be measured accurately, can be replicated across all these trials, and that something is clinically meaningful. And this greater than or equal to 2 millimeters was chosen based upon a litany of previous trials where it never actually achieved significance. Subjects were randomized, and this is phase 3. Now we have cumulative data for each of these trials. And the primary outcome in phase 3 was the proptosis responders, meaning the percent of patients who achieved at least a 2 millimeter reduction in proptosis with teprotumumab. And then we also wanted to see the reduction in clinical activity score and double vision and all those things that I've already talked about. And I'll show you data for each of those. So this is what happens when a patient is given IV saline for 24 weeks. Not a lot, maybe even a little bit of worsening, which happened through here. And I'll show you the cumulative data, but I think it's always great as surgeons that we look at photos and look at the type of patients that we're treating. And you can see that not much happens. This is a patient of mine, and now I have quite a few patients, and we can show quite a few different results, treated with teprotumumab. And this was before teprotumumab, a gentleman that presented his case at the FDA meeting. And he was almost ready to lose his restaurant because he could no longer function. He could no longer see. He was getting double vision. And you can imagine just how uncomfortable he was. And this is after 24 weeks with teprotumumab. It didn't take 21 weeks to make this happen. The effect started very rapidly within 2 doses. And that's what we've seen most commonly. And you can see a dramatic reduction, 5 to 6 millimeters in proptosis, just with teprotumumab, no other treatments before or after. So let's look now at the data and what the data show us. We certainly know that the clinical activity score goes down very quickly. But even in placebo, there's a reduction in the clinical activity score. It declines over 24 weeks. But you can see almost a 4-point drop in the clinical activity score. It's a 7-point scale that occurs very quickly. And these people all started at 4 or greater. So it's quite the reduction. And we'll show there's a variety of data. Well over half of these patients, 61% as a matter of fact, had a CAS of 0 or 1, compared to 20% of patients just treated with placebo. So very rapid and powerful reduction of the swelling. That's great for swelling, but what about proptosis? And this is really what I was most interested in, is how many patients are becoming responders. And you see that this is really rapid. As early as 2 doses, 54% of patients are responding to this treatment, and it continues to get better to almost 78, almost 80%. Now, this is an intent to treat analysis, which is required by the FDA. That means if someone's dog got sick and they missed their appointment that day, And even if they had a great response, but if they didn't show up or they missed their appointment, they were marked as a failure. So this is quite a stringent guideline, that we'll see. And we'll look at all the data. We can look at even individual patient data just to see how dramatic the results were. And this is just 2 millimeters. Many of these patients went on to develop much more and much better than 2 millimeters, which was just the response criteria. This is the data demonstrating the proptosis reduction with teprotumumab. And you can begin to see, and there's also combined data that's very similar between both trials that demonstrates more than 3 millimeters reduction in the proptosis that occurs from the time this drug is given. And you can see that this occurs very rapidly. I've now treated about 60 patients. I was adding them up the other day, and I was kind of surprised that between commercial and different trials, up to about 60. And, it's always amazing because the patients come in at that 6-week mark and they're just thrilled. And they post videos on social media and they're just thrilled and happy. And because they're already seeing almost a 2 millimeter reduction and all the swelling is going away, their double vision's getting better. So it's not just one aspect. These patients, this is always what I consider the hug time. At 6 weeks, I get the hugs, but with social distancing, I'm getting less hugs and more elbow bumps. But what can you do? The overall responders is just a combination of CAS and proptosis, and you just expect almost identical the number of responders. This I always think is one of the most important graphs. And this is from phase 2. Phase 3 looks almost identical. And what we can see is that the patients in placebo, some go up and better, some don't, and they're kind of all over the place. That's exactly what you would expect. A lot of these patients do get a little bit better. Some patients that just naturally get better, 3 millimeters. And there are lots of patients who get worse, 2 or 3 millimeters. And so I think that that's always great when we bear in mind of saying, oh, something seemed to work. This is one of the first studies that's had a large natural history that's been followed so closely. And I think we've learned a lot about that. But what we can see also here is that none of the patients got worse. In fact, all the patients got better. Some of them didn't actually meet criteria, very few, where they just had 1 millimeter reduction, but about almost 80%. And they also got better from week 12 to 24. Almost 60% of them did, and it still had an improvement during this time period. But you can see that some of these patients, 4, 5, 6 millimeters in reduction. And the reduction of proptosis, as you might expect, was greater in patients that had a higher baseline proptosis. Probably patients with worse disease got a bigger effect than those with maybe less severe disease. And I think one of the most interesting observations that we were able to make is that we had MRI scans and CT scans from a few of these patients, not all, but several of these patients, and we were able to demonstrate that the edema and the inflammation behind the orbit goes away. But has anyone ever seen muscles of a thyroid eye disease patient get smaller? I personally have not. And these muscles, and we've done volumetric analysis demonstrating that the muscles in the orbit get smaller and that the volume actually improves of these muscles in many of the muscles that are affected, about 50%, almost coming back to the normal range. And so really quite surprising and that this drug has such an effect specifically upon the disease process. And so we know that the ideal treatment is both decreasing the inflammatory signs and reducing proptosis. And I think that we can say that it's probably doing that. Now what's next is reducing double vision. And the data also shows that it is. We measure double vision via a Gorman scale, mostly because there's a large group of endocrinologists and a very heterogeneous group of measures. And the Gorman scale was at least something that was approachable for the entire group. And what we demonstrated is, there was an appreciable improvement as early as week 6, that then continued to get better over this period of time, over the study period of time. And we can see both quality of life overall in the improvement, and also in visual functioning and in the appearance for these patients. So both was improving the double vision and the quality of life. And again, checking some of our boxes. So, and then thinking about, well, what are the potential side effects of the therapy? And the safety profile in phase 2 and phase 3 were very, very similar. And we have overall data too, that in a much larger segment, but it really is very similar to what we show here, with a relative paucity of serious adverse events. Well, what were the adverse events? So we had potential infusion reactions, no anaphylactic reactions. There was some hyperglycemia, especially in the teprotumumab group. And it was interesting, but this was really due to only in patients who had a previous history of metabolic abnormalities and carbohydrate metabolic abnormalities. Also, muscle spasms in about a third of the group. These were usually very well controlled, would occur at night, would occur in, just having a little spasm. And then hearing impairment. This is, a term used by the FDA that you have to use, that was used, but what it was in speaking to these patients, it was as if their ears were full and they had a fullness of the ears. And then this typically resolved in these patients anywhere from a day, 24 hours in someone who had a sinus infection, to a few months then later where there was an improvement. And none of these were in any way for the patients triggered their removal or discontinuation of the medication. Now, does it eliminate surgical treatment? Well, I think that's still an unanswered question, but I think we're on the right path. We know that you get about a 3 to 4 millimeter reduction in the proptosis change with decompression surgery. And I think that, many of the surgeons here, we can say that we can get more, we can get less, we can customize it. And I'm going to give a little talk about that at the end here. But I think that the most important part is that what I can't do is that I can't do decompression surgery and improve double vision, at least certainly not consistently. And I'd love to learn how to do that. And I also can't necessarily reverse all the inflammation and the edema and the swelling and everything that accumulates in this disease, in addition to the things that I can deal with surgically. So I think that it really, we have to think about combining these modalities, or certainly thinking in different terms for the medical therapy. So we can certainly see that we now have, with a phase 2 and a phase 3 study, both published in the New England Journal, and they're really demonstrating that teprotumumab is highly effective in the proptosis reduction, double vision, and for shrinking these muscles. And I think that shrinking the muscles and showing this volumetric reduction in both the muscle and the fat component really is striking with this disease, and really something that I think will be worth exploring mechanistically as we move forward in the future. I did, just to balance and to present all aspects, I did want to just present a little bit about what we've been working on with single stage aesthetic function to thyroid eye disease and rejuvenation. And I'll go through some of these slides quickly, but I do think that even with an advent of a new therapy, there will likely be need for surgery for thyroid eye disease patients. I don't think that surgery will go away completely. I do think that the type of surgery we do will be completely different. I think that we'll probably be doing a lot less. And these patients also might even be finding their way more into our aesthetic practices than our functional practices. But I think of aesthetic functional reconstruction in these patients is about looking good and feeling good. It's kind of like that quality of life diagram where we had visual function, how patients are seeing and function versus how they look. And it is about the downtime and such. And we've been working very hard for the last 7 years or so on just doing a single stage reconstruction. And when I mean single stage, I often mean facial work. I mean fat injections around the face, buccal fat removal, brow lifting, even facelifting during this time, or mid-face lifting and blepharoplasty. And I do think that that can be achieved in a very high degree of patients. I don't do that. The only caveat is in patients who have vertical strabismus. Unfortunately, I often do have to stage out those because the eyelid surgery can be a bit too unpredictable in some of those cases. So I think, some reason here. So, but I do want to at least cover this topic because I think it's interesting and I think people find it kind of fun. Form does follow function, and our goal is to improve upon the pre-disease appearance. And we try to do this in one surgery. Lots of factors to customizing this surgery. Patient's goals, how severe the disease is, their bony structure, soft tissue structure, what else do they want to achieve, or what else has changed in their disease? And then what are the surgical implications of prominent eye? Just by the eye being prominent, that changes the lower eyelid position, the lower eyelid contour, the upper eyelid position, how the face actually fits in symmetry. So all those have to be taken into consideration and approaching this in a single stage. So it's not just about achieving a proptosis reduction. So the first is to reduce the negative vector. And again, we all know that the negative vector is the fat man with the pants. You have a very large bulgy eye and it forms a negative vector. There's very little support from the pants for this overlying belly. And in the same way, the prominent eye overlies the mid-face and something has to be done. One has to be moved back or the other to be moved forward. You just can't tighten the eyelids and try to get away with it. It makes the negative vector worse. Here's a woman with a very negative vector. She's Asian, and it has completely changed her facial appearance. We can see the negative vector. And normally the eye is ensconced in soft tissue, sits in the orbit very nicely. The lower eyelid contour is supported by the orbicularis muscle, the midface. But then when there's a prominent eye, you no longer have that support. And just by the eye being prominent, it changes the entire aesthetic and the entire aesthetic features of these two patients. So what do we do? Well, the first thing we do is we have to deal with the negative vector. And that is often with a customized decompression surgery. I often do medial or lateral. I start with a lateral. I almost never now take off the orbital rim, but we do a customized lateral decompression. And I'm not really going to get into the details of that, the special technique that I use, but I think everyone has kind of developed their own technique over many years. But I do want to mention the complications. And I do think that if patients have a fat dominant disease, no matter how much decompression you do, lateral or medial, we looked at about 57 patients, and the rate of double vision is very low. Now, if their muscles are larger and they're infiltrated, then even a lateral decompression has about 5%. Usually it's about 3%. We've expanded the numbers here quite a bit. But adding on a medial in a strut-sparing medial, it does increase those numbers, especially if they have larger muscles. And so those are always the patients that I guide and tell them about their relative risk. Again, thin strap-like muscles, just bulky disease, very little risk no matter how much you do. The others, much higher. So what do I do? And again, I'm not going to get into the technique as much, but I do a technique where I try to maintain the periorbita close until the end, not damage the muscle. And it's just, a lot of small issues, but it's beyond what we want to talk about today. So I do think that the ability to alter this prominent eye not just improves the proptosis, but it improves the appearance and the function, and it's dramatically reduced my need for eyelid surgery, either lower or upper eyelid surgery. Now, less than 5% of my patients really need lower eyelid surgery if it's a primary case and we do an adequate decompression. I'll talk about that. So part of the lateral is, which is usually the first wall of choice, I usually use a deep lateral. And this gives an axial reduction. And it has to be behind the zygomatic-temporal nerve that kind of shoots through here and then runs up. But it has to be deep to the temporalis. And this bone anteriorly has to remain intact to prevent hypertelorism and really kind of debulking the periorbital without axial displacement. The action all happens deep. And this is some of the results that we can get with a fat and lateral. I usually take fat for almost everybody, and a lateral and superior decompression and about 6 millimeter reduction. She had relatively small muscles, and no additional surgery was needed. Pre-op, she had good eyelid position, a little bit of eyelid retraction, but even that tends to improve over time. Just another example of someone with about a 5 to 6 millimeter improvement in reduction. Still have some bulkiness due to just the thickness of the skin from thyroid eye disease. So someone who had optic neuropathy still has a little bit of erythematous skin changes, but really not due to active disease. He's nice and stable at this point in time. So I think you can create a natural lower eyelid appearance by customizing your decompression technique and hopefully avoiding additional eyelid surgery. And I do that by taking out the basin here, this zygomatic basin in blue. That tends to drop the globe by a millimeter and a half without an increase in double vision and return the eye more to a normal contour. And we did this just with eyelid contour mapping before and after decompression. It's kind of demonstrating, you can see a reduction in the lower eyelid retraction, not by anything besides moving the globe back, and also in a little bit of an addition, taking out that inferior bone and allowing the globe to drop. And so it makes a nice combination of improving that and returning a normal eyelid contour to most patients without the need for additional surgery. So I'd really kind of encourage people to look and think about that. This is a patient where we did a mediolateral and superior fat, but she didn't need any additional eyelid surgery. So we were able to do everything, and the eyelids came up just by reducing the prominence of the eyes and improving that lower eyelid position. Just another case here, a little bit of a less severe case, but the idea is that, pretty much the same. And the same here, just another example, reducing that lower eyelid retraction. So I think the other thing is we begin to expand our thought process of doing a single surgery. What else can we do during, decompression surgery? And I always do bilateral cases. Well, a lot of times I'll release the eyelid retractors if one is a little higher than the other. I'll often release the orbitomalar ligament, do a mid-face lift, even cheek implants. And these are some specific patients. Now, this was just a non-surgical patient where this did a little bit of filler to accomplish the same goal. But this is a patient who's much more severe and really requires the use of something to get rid of these bags, remove a little bit of a blepharoplasty at this time, can even lower the upper eyelids, but then releasing this orbitomalar ligament will dramatically, and giving the cheek a little temporal lift, will dramatically improve the softness of the lower eyelid. So no grafts, nothing else done in the lower lid except for those particular procedures. And just another example, releasing the lower eyelid retractors, trying to give as much improvement of the lower eyelid. Didn't remove any fat here, but just releasing the lower eyelid retractors with decompression. And the orbitomalar ligament, much more severe. He requires a decompression, which I think in this picture he's already had, but really requires an implant placement to give that augmentation of the cheek, mid-face, and orbitomalar lift, just to improve that lower eyelid retraction when you've kind of reached your maximum of what you can do for someone. This is just a very similar case. Also did a blepharoplasty transposition, a little bit of a orbitomalar onlay implant, and then reduced a little bit of the upper eyelid bulk too. So I think it's important to also address the upper eyelid. I think it's certainly possible to do. I often will, if it's a 2 millimeter reduction, do it internally under general anesthesia. I feel that I'm comfortable enough. I've done so many now. But if it's something like this case where there really does require a much larger reduction, then I think you have to consider doing it under MAC, which I do a blepharotomy, and then go ahead and convert to general and do the remaining decompression. That's kind of what I do. Brow fullness, I think, is very nicely treated by taking out this superior bone. This superior bone is really great to remove, especially in Asian patients, or especially when there's a little lacrimal gland fullness. You can take out this bone and then tuck the lacrimal gland right behind it Don't take out the rim, which I don't anymore, because then you can tuck the lacrimal gland and it really forms a beautiful brow fullness. And if you want to, you can even do a little temporal brow lift just to give a nice improvement. This is just an example of that Asian patient that I told you. You can see the dramatic changes she had with thyroid eye disease, and she has fullness up here in addition to very prominent eyes, especially for Asian. So what we want to do is reduce this lacrimal fullness through periosteal incision, take away the axial reduction and improvement, and without using an eyelid crease incision. So just use it in a corner crease incision, just kind of splitting the canthus just a bit, and then releasing, and then subperiosteal dissection, no orbicularis incision. And then a nice, I think, improvement of her lower eyelid contour, reduction of her prominence, and then avoiding crease, which I often have to do in my Asian patients, especially in Shanghai. And reduction in proptosis, all through that hidden incision. This is one of the last examples, but this is just where I've been really doing a lot more facial work. And now I'm focusing upon taking out the buccal fat. I think it expands in patients with thyroid eye disease. They all hate their cheeks, even if they've never been on steroids. And they almost feel that it's a golf ball that is essentially replacing their buccal fat. So I do a gingival incision inside the upper lip, go in, take out some of that buccal fat, and it gives a really nice improvement. You can do this with a little bit of fat injections. I often do those in the temple and the brow area. You can do it with a little bit of a lower bleph here done as a transconjunctival bleph fat transposition, and doing a decompression and just a tiny bit of an upper bleph, skin bleph only, just to open up her eyelids. And I think that, you know, for many of these patients, they really, really do enjoy that improvement of the appearance, and you can accomplish this in one surgery. So I think the aesthetic result is critical, and I think it's an opportunity not to think of thyroid patients just as functional, or really not having increased or complications that, you know, wasn't anticipating. It is much harder to do a transpositional fat blepharoplasty in these patients. Many times I'll remove fat instead of actually trying to transpose it, because it can be much more vascular. That's the one thing I have noticed. But otherwise, most of the techniques really work great, especially fat injections into the cheek, temple area. It really balances their face beautifully, and removal of buccal fat pad, probably the highest degree of satisfaction procedures that I do besides the decompression. And again, I just want to thank you. I'm going to stop my sharing and thank everyone really for allowing me to present, and I hope I didn't go too far over.
Yo junto todo el día pelotas en mi casa, hago así.
For everyone, because everybody wants to give you a big
tirar el baño. Y que agarrar les dije que tiraban en el ahora nunca más.
Cuando uno va a la charla y todos aparecen en el video, parece que ver la cara a los demás.
con los micrófonos
En el inodoro, pero huecos así. Cuando el peinal se me caía huecos. Cuando me bañaba, otro hueco.
No se ve.
mi amor. Bueno. Ahora, thank you so much. That was the big noise of the applause. I'm giving you audio.
Okay.
So there you are. Thank you so much. That was so impressive. I mean, it gives us, you know, it's wonderful to see how, you know, there's finally something that does work, and your cosmetic results are amazing. Jorge, and he's up, and Rosa, she's up, because there's a lot of questions from the public. So, Jorge, ¿quieres partir tú?
Okay, muchas gracias. Okay, well, Raymond, just again, amazing though. I mean, I was impressed last year, and I'm speechless. This was an amazing presentation, very didactic, very thorough. I have a couple of questions from the audience, and one actually from me, and then I'm gonna let the other panelists discuss as well. So one question is actually from Jose Luis from Mexico. Jose Luis Tovilla is asking, like, right now the Tepisa is not available, And so what do you recommend in Mexico, like for patients with mild thyroid eye disease regarding the initial treatment? Do you still recommend steroids, or what do you recommend until this becomes more available worldwide?
Yeah, well, we really hope that it does become available worldwide. And I know that, there are certainly plans on that. And, I'm not privy to any of those, but I know that that's one of the biggest issues is the availability. But, at least we now have an opening, and I can certainly see that growing and becoming available, hopefully in the not too distant future. Mild disease, what I say is it may or may not be mild to the patient. Some patients I'll look at and they are, they don't go outside. They've canceled everything that they do. They've changed their lives, and I would classify them as mild. But then to them, it's not. And so for some patients like that, I would consider a small dose of steroids, but only for symptoms. I really try to steer them away, because if they're not going to have a symptomatic improvement, I can't really say that they're going to have an improvement of their eye bulging or other things, because it hasn't been shown, with the data. So I try to figure out what's bothering them the most. I tend to do a little bit more surgery early on in the disease. I think that reactivations do respond a little better to steroids. But if they're incredibly bothered, and they've tried selenium, they've tried other things, and they have mild disease and it's just not available, I don't think it's a bad thing, as long as you really carefully weigh that you're treating the symptoms, and then how you weigh that, what that means to the patient's, life and how they're functioning.
Excellent. One more question is,
A ver,
so somebody was asking regarding the patients who smoke. Were they how are they responding to the TEPEZA? I mean, of course, discouraging smoking, but were they included in the study? And if they were, how did they respond?
Yeah, so I didn't show that slide, but the great thing to know is both in phase 2 and in phase 3 they were included. We did not want to make any distinguishing. We did not want to exclude smokers, because this is the real world. You're going to have to use something in the real world to treat smokers. They responded exactly the same, which I have to admit, even as an investigator, I was a little surprised. Smokers never respond exactly the same, but they had, and I can always probably try to pull that data up, but it was the exact same reduction in proptosis and clinical activity score, et cetera, et cetera. So, and they composed about 20% of the patients in both studies. It was at least 20%.
Excellent. And then another question from the audience. This was us from Martin in Argentina. If you can just explain, right now in some countries they do have the tocilizumab available, and what are your thoughts between? Of course, you explain why TEPEZA works better, and what are your thoughts when they both become available in the same country, and which one will you pick, and if you see a role for combining both medications?
Yeah, well, when Terry Smith and I were talking about, well, what are the candidates here? What would you want to impair? IL-6, which is what's effective with tocilizumab. It's right up there. You stimulate fibroblasts, and you always get a response of IL-6, and it always seems to be exaggerated. And that occurs early in the disease process. So probably that spike of IL-6 occurs somewhere early in the disease process, helps to drive that, and it may be on a very cellular basis. What we've seen, with tocilizumab, and is available here in the US, is that before teprotumumab became available, is that a lot of people did like tocilizumab because they could probably see a reduction in the swelling and the inflammation. It hasn't really borne out that it reduces the disease or reverses the disease. And I've used both. And, and I've used rituximab. I've also used a variety of the other ones. And I have to say that the onset of action and the completeness with teprotumumab, just comparing the two head to head, has really just been, overwhelmingly, spectacular. And so, that's been, I've had patients come off of one onto the other now as it becomes commercially available. And it's been very, teprotumumab has been very dramatic. So I would certainly anticipate that, Tepro would continue, and what I've heard from my colleagues, do very well in a lot of these patients. And, it's too early to know where the role of tocilizumab may fall. It does in some ways have a better side effect profile than steroids, but I think you just have to be a bit careful with it. It is impairing the immune system, but at least much more specifically. So, I think that, without teprotumumab, you're those would be my go-tos: tocilizumab, steroids. What can you do with this?
Well, thank you again very much. And Rosa, if you want to continue with the questions. Thank you so much again. Amazing.
Thank you, Raymond, for your talk. It was very impressive. Everybody's very happy. You have a lot of compliments on the audience. I just want to ask a few questions related to the talk. Everybody here in Latin America wants to know how much it costs, at least for you, because for us it's very hard. I know in the US sometimes too, but especially in South America, sometimes it's very hard for the patients to be able to pay for this kind of medication. So do you have an idea of the cost right now?
Yeah, so so it kind of gets outside of my area of expertise here, but the cost is expensive. So if you went out and you purchased a retail price of teprotumumab for all 8 courses, it is somewhere around $300,000. And so now in the US, most of that, if not all of that, is covered by insurance because there's copay assist and a variety of things. But it's not something where, unfortunately, you could say, oh, we'll send you our patient up to the US. And what that would be a cost that I think would be prohibitive for most people. And so I think that's, right now, one of the issues.
Okay, so the other interesting question is about diabetes, and if you check hemoglobin before the treatment, if it's possible to give it to diabetic patients.
Mm-hmm. Yeah, great question. So in the trials, we did follow hemoglobin A1C very, very carefully. Turns out that less than about 10% of patients have any abnormality, but those are patients who had already been pre-diabetic or had a higher fasting level. And those are the patients who are prone to have issues. In diabetic patients, it's actually been reasonably well tolerated, but you have to probably adjust their medicines, follow them closely. In my diabetic patients, I have had patients who I've had to increase their metformin or other things, but it's been mostly on that scale, like dosage adjustments rather than diabetic ketoacidosis. There's been none of those types of cases, but you do have to follow that carefully in that select population.
So the other comment or question was about the adverse reactions that in the trial, it looks like they were mild compared to rituximab or tocilizumab adverse reactions. So do you have an experience? Have you had the people who died or have major reactions with it, or not at all?
No deaths, knock on wood. But you never know. There always could be something in the future. We give phenylephrine drops, and people can die, and I've seen that. So but in this case, and in the previous studies with teprotumumab, the results have been fairly impressive. That they've been relatively mild and controllable. Now you have to be careful with diabetics. You also have to be very careful with anyone with inflammatory bowel disease. In phase 2, a patient who was treated with inflammatory bowel disease had what seemingly was a flare, and had a much worse disease and actually then had to have surgery. So in phase 3, we had to eliminate patients who had a known inflammatory bowel disease. So I think you have to be very careful with that group. And you have to be very careful in pregnancy. So I monitor, any young woman, anyone of childbearing age, to make sure that they don't get pregnant on this medicine, because it's something that's very, very important also, because it could, certainly, harm the fetus.
Great. Well, I'm sorry, there are so many questions that I'm going to keep asking you some things. So
sure.
There are a few people in the audience asking if you're thinking about doing the trial of against steroids, trying to figure out how the differences in both.
Yeah, so it's always an interesting question, you know, but you have to think of it as in terms of therapies that have been shown to be useful. And the FDA is kind of very clear about that, and that their opinion about steroids is that they have not been shown to alter the disease. They may alter the inflammation, but they haven't been shown to alter the disease process at all. So it's one of those things where there's really no impetus to compare the two, because one is an FDA approved therapy and the other one is not. So it's, you know, would you then compare it to, you know, all the other therapies or aspirin or selenium? So it becomes almost where, you know, I think you have to reach a benchmark for those other therapies to show that they're effective. And then I think it would be very fair, if there is another therapy that gets approved by the FDA, to compare them side by side. But until that, it would be, you know, I'm certainly not planning on that. I've seen, you know, so, you know, with all the data that's available, I just haven't, certainly wouldn't be planning on that as far as a trial I would be running.
So there's another interesting question here, that what are your thoughts about using it for optic neuropathy or IgG4 related orbital inflammation?
Yeah, two great questions. I've already treated patients with optic neuropathy. It works very fast and very nicely. I've been very, very impressed. It's at least as fast as steroids, and I've noticed even after the first dose reduction, we've followed patients with a dramatic improvement. Those patients were excluded from the clinical trials. So this is now the first opportunity that we're having to see those patients. I have not, and I don't know of anyone who's treated IgG4 disease, but I do think that it's really an interesting question, because much of the same overexpression of the IGF-1 receptor is found in other processes, including the orbit of IgG4, but also including even recent trauma and even in the joints of rheumatoid arthritis patients. So I think that in some other inflammatory diseases, there can be an overlap of this IGF-1R. And I think that, you know, could bear some interesting testing, but I don't know of anyone who's tested that yet. It's usually hard enough to get this medicine for patients with thyroid eye disease right now.
So there is another question about the MRI that you show on your presentation with the production of the muscles. So someone from Mexico wants to know how long during the treatment you had this difference, like in between, how many doses of treatment you have before showing that difference?
Yeah, so we're preparing a paper now where we've looked at about 10 of these patients, and we've only done scans at the very beginning within 3 weeks of starting and within 3 weeks of finishing. So we don't have a scan in the middle. So I can't say that at this point in time, that's when you saw it. But what we do notice is we do notice a gradual reduction in the proptosis and a continued improvement. So both those scans were shown at the beginning and end of the treatment.
Okay. So I'm going to ask you again, or ask you to repeat the cost. So we're going to say it in Spanish, because there was a misunderstanding about the amount. It was $300,000 about all the treatment, right? Around that?
Yes, yeah, for the total cost.
So el costo en Estados Unidos está entre, como dice Jorge, entre $200,000 y $300,000 el tratamiento completo, que dice Raymond que se cubre por los seguros y que por eso para ellos todavía no es un problema, pero que la expectativa es que en la medida en que se haga más usado este medicamento, baje el costo, ¿no? Eso para los que les quedó la duda si eran 3,000, son 300,000 desafortunadamente. So there is another last question for me, or like I'm reading here, it's not my question, but so about the age group. We know the age group that you picked for the trial, but do you think it has a role in kids as well for thyroid disease and children or elderly people?
Yeah, so in the phase 3, we expanded the age range up to 80. And we don't see that's just an artificial cutoff, but you could, I think, and in fact, older people, you may not want to take to surgery, so it may be a better option, or patients with vascular disease. I've used it now in some patients who are over 80. In children, it's a tough question because I think the effect of the IGF-1 receptor, you have to make sure that they've reached their linear growth potential. And so that I think is very important to work with a pediatric endocrinologist, and it'll probably include patients in their adolescence. I have now a patient who's 15 who I'm considering putting them on this because they have the appropriate disease. But I think you have to be very, very careful with, young people, at least their, of their growth potential, and then just making sure that you feel very comfortable with the risk and benefit. So I think that'll be slowly, just making sure we're safe.
Okay, can I ask you another question?
So you bet.
They are asking why the trial is 24 weeks treatment or that many treatment, and if you think it might work if you use less infusions.
Yeah,
we're always thinking about saving money,
Yeah, so it all depends on whether you want the the real answer is, we didn't know. When you design a trial like this, you just don't know, but you have to take educated guesses as far as how many you need. It usually takes between the third and fourth dose for the drug to come up to reach equilibrium and to be at its highest rate, and that will stay there. So even after the third or fourth dose, you finally get up to what we think is the therapeutic concentration. Now, a lot of patients have responded until then, but we don't know whether if you stop early, will that mean that the disease will come back or won't it? I think that, my guess is that there will probably be some future trials along that line to know those questions. But we honestly chose it initially to think, well, this covers the active period for most patients. And this should be long enough. If you don't see an effect by then, you're not going to see an effect. And it allows the drug to come up to its equilibrium over, those many doses. So that's the answers. It was an educated guess at this point in time. And, but we have to do a little bit more data to know whether that's the right amount or not. We just don't know.
So have you seen any recurrence on your patients after the 24 weeks or so?
Yeah, so recurrence is probably around 5%. So the results appear to be long-lasting and durable, but there are about 5% of patients in trials that seem to have a recurrence. And actually, one of them was my patient. He had a recurrence. It was about 2 or 3 months after he stopped treatment. We put him back on the treatment because he was part of the trial, and it went away again, and he's never had a recurrence since. So there may be some patients that have really severe disease who require a little bit more of the drug, more time, and there may be others who require less. It's just, we don't know that, but it appears to be a very low reactivation. We were worried that maybe everyone will reactivate, or maybe you're just pushing the disease down the road, but that doesn't appear to be the case. It really does appear to be long lasting, and that, this seems to be a true cure where the disease doesn't come back.
Mm-hmm.
Great.
So, go ahead, please.
Danny Vile, do you have any questions? ¿Algunas preguntas por allá?
Bueno, I have no any question. First, congratulate you for a very, very nice exposition and so easy to understand for some people who don't understand so much as Graves. I read your papers 3 times. I enjoyed it. It was a perfect paper. It's for people who are trying to experience with make papers. It's excellent. You and your great friends.
Thank you so much.
The second thing is a comment, the same make you Rosa Balcells, that when, I don't know, 4 or 5 years ago, Jim Garrity published his rituximab work, who was with moderate response, I said, rituximab, rituximab, rituximab. Now we have the solution. Here, it's impossible to buy rituximab and everything. It's the same comment as Rosa makes you. But, bueno, we are in Latin America. Latin America have most of countries who are poor, and, bueno, we have no other way. But congratulations again, Douglas. Was beautiful, beautiful. I enjoy a lot, a lot.
Thank you very much. Thank you. Thank you so much.
So that was absolutely fantastic. There's still a lot of questions. I think we could keep talking about this for ages because we all love your lecture and we all love thyroid eye disease. So thank you. Thank you so much for joining us. It's a really special time for SOPANOP, and to have you talk about this real, revolution in thyroid eye disease. We're looking forward so we can use it here in Latin America. Have you heard anything about that?
Yes, it's a revolution.
I have not heard, but I will be sure to convey those, the enthusiasm of wanting to have this more broadly available. I know I was speaking to Martin Devoto about the same subject, and it's, I enjoy taking care of patients, so I would love to, it always feels, disappointing that, that we can get excited about the therapy, but it isn't available for everyone. So hopefully we'll be able to overcome that soon, because that, really, I think could benefit, and it'd be so, I think, beneficial to so many of our patients. And so I hope that does happen soon. It unfortunately is not my decision. I don't have any financial interest in the drug, but hopefully we can convey that very poignantly.
So our leitmotif.
Talking about Martin Devoto, I don't know if you can turn his microphone on, Jocelyn, because he wants to ask Raymond a question himself. Is it possible to do that?
We were actually kind of finishing, but Martin, si tú insistes.
Very short question. Hi, Ray. Thanks for sharing this wonderful future present drug. I noticed from your trials that within the second dose, you get a very good response. Considering the difficulty of the cost related to this treatment, could you consider a shorter course for patients in the future, like an idea? I know this is out of the trial, but would that be an interesting line of thought?
Yeah, I mean, I certainly think that, that's going to be something that's going to be important to address. It was even in the FDA meeting where I testified, do you need shorter, do you need longer? And certainly in this conversation, it's financial, but also just for what, reactivation. Do you need, how would you space out this course? I have to say that, when you start a trial like this, you give it a, 10 or 20% chance of working. So, we haven't, figured out all the, the permutations, but I think that that's really high on the list as far as something that needs to be addressed. I hear it time and time again. I think it's really important. And I just don't know that, of how shortening the course would do that. I do see really a nice continuation and improvement, even in patients week 12 to 24, especially in the more severe cases. So, it's hard for me to know at this point. But top of the list.
Thank you so much. Our leitmotif and our slogan is Todos somos SOPANOP. Everybody is SOPANOP. So you definitely qualify to be part of SOPANOP. Thank you so much.
Well,
you're
I just want to
invited
thank
to
you.
Bravo.
Thank you.
Everybody's applauding. So
Thank you
I'll send
very
you
much.
the pictures later. So you're also invited to join us. Cristina is going to nos va a anunciar quién es la que va a dar la charla el próximo jueves.
Well, thank you very much, Raymond. Very, very nice presentation. And
Tienes que hablar más fuerte, Cristi.
Excellent result. And well, I talk in Spanish porque nuestra presentación para la próxima semana y sobre todo porque lo dije al principio, queremos hacer nexos con todas las sociedades de oculoplástica, todos somos SOPANOP. Nuestra próxima presentadora el próximo jueves es la doctora Patricia Caishi, que es la presidenta actual de la Sociedad Brasileña de Oculoplástica, y vamos a tener una excelente presentación sobre ptosis palpebral. Así que los esperamos a todos el próximo jueves, la misma hora. Cuídense mucho y muchísimas gracias por estar con nosotros todos los jueves. Thank you very much.
So see you all later. See you soon, Raymond.
And again, thank you all so much. It's truly my pleasure. Thank you.
We appreciate it very much from the bottoms of our heart.
Ciao,
ciao. Bye, bye, everybody.
Las cámaras.
Estamos ahí sacando fotos, pero ya nos vamos, ya nos vamos. Bye, bye.